Hello and welcome to Radiology and Subspecialization, Success Strategies, an AuntMinnie webinar. My name is Brian Casey, Editor-in-Chief of AuntMinnie.com. It's no secret that radiology is becoming more specialized every day. In the interest of delivering better and more personalized patient care, radiologists are focusing their training and practice on more and more detailed areas of anatomy and technology. But this phenomenon raises a host of new questions. What are the advantages and disadvantages to radiologists who pursue subspecialization? What tools exist to help radiologists in this new environment? And what role will general radiologists have in the emerging era of subspecialization? We've assembled an excellent panel of radiology key opinion leaders today to address these questions. Dr. Mark O is a board-certified radiologist and president of Radsource, a leading provider of medical imaging interpretation services, especially in orthopedic and neurological MRI. Dr. Michael Brown is a board-certified radiologist with Carolina Radiology Associates, which provides radiology coverage throughout South Carolina, North Carolina, and Georgia. And Dr. Vikram Krishnasetti is a board-certified musculoskeletal radiologist and Associate Chief Medical Officer for Clinical Technology and Data at Radiology Partners of Columbus, Ohio. Thank you all for being with us today. We're going to start with introductions and then we'll get to our discussion. So Dr. O, can you describe the type of radiology practice you work in and the type of patients that you typically see?
Yeah, thank you, Brian. Well, I'm a founder and president of Radsource, and we have two business lines. We are a nationwide provider of subspecialized MRI interpretation. We also provide a technology solution, a hybrid hosted PACS product we call Proton PACS. So I spend a fair amount of time managing our business, but we have a great team that allows me to continue to practice radiology, which is important to me. That practice is almost exclusively musculoskeletal and neurological MRI interpretation.
Great, perfect. Dr. Brown, how about you?
I'm a partner in Carolina Radiology, which is a 44 radiologist group that covers pretty much the entirety of the northeastern part of South Carolina. We have two divisions split fairly equally. We are a radiologist-owned practice, and we do provide subspecialty coverage. I myself am a general radiologist. I'm probably one of the last group of trainees that finished that may have entered the job market without a fellowship. I finished my residency in 2005 and have been at Myrtle Beach for the last 15 years. So I have developed an idea of what's needed on the specialization front and understand that you do still need to learn and continue to develop skill sets beyond fellowship and radiology. But I am seeing that overall, this is a market that's leading more and more towards subspecialty interpretations for all of radiology.
Great, seems like it. Dr. Krishnasetti, how about you?
I'm a partner in Radiology Partners, which is one of the largest practices in the nation. We cover basically all across sites all across the nation, but Radiology Partners is a practice of practices, and so we have multiple local practices that operate individually as well. And I'm a member and a partner in Columbus Radiology, which actually serves the entire state of Ohio. So we have hospitals in Columbus, Cincinnati, Toledo, Northeast Ohio, across the state, and we're about 120 radiologists within the state of Ohio covering the state. And I do a lot of administrative work with Radiology Partners as the associate CMO. I'm also the vice president of Columbus Radiology, but I'm able to practice and do musculoskeletal imaging and body imaging, but also a lot of general radiology as well, given that we cover a variety of sites, including communities, community hospitals in rural areas up to level 1 trauma centers in cities. And so we see quite a smorgasbord of different cases and different levels of acuity.
Great, perfect. Good. So if we could start with a couple of questions that I'd like everybody to address. And Dr. O, let's start with you. What do you think is driving the current push towards subspecialization in radiology?
Well, I'm always hopeful that, even though it's not always the case, that our decisions in healthcare are motivated by quality and patient care. And I think there's little doubt that we as radiologists can provide better patient care through a subspecialized approach, allowing us to route studies to radiologists best equipped to interpret them. We're seeing more and more that referring doctors, even patients, are demanding that the high-end imaging studies be interpreted by people with specific expertise in that area. And we're now even beginning to see this approach adopted by payers. The other thing that drives subspecialization, I think, is economics, because if you're in a competitive market, larger cities, simply being better at something allows a practice to capture more referrals and grow their market share. And the other business case is efficiency, since radiologists will obviously be able to work faster while still maintaining a high level of quality if they're interpreting studies that they're well-versed in reading and accustomed to doing so on a daily basis. So in this way, the practice wins, the referring doctor gets better service, and most importantly, the patient gets the best care.
Great. So Dr. Brown, what are some of your thoughts on what's driving this push toward subspecialization?
Yeah, I agree with Mark that I think all of medicine is becoming more and more specialized, and so I think radiology is falling in line with that. I think the one unique aspect of radiology that's really taken off in the last 5 to 7 years probably is the IT side of things. The ability to get the study to the person able to read it best is, if you can't be an internist and specialize in diabetes care, and if the patient physically isn't in your office that has diabetes, you can't provide that service. But as a radiology entity, we can bring in studies from disparate geographic regions. We can get those studies to the right person. 15 years ago when I started practice, you depended on physical presence at a site because you may not have digital images. It may have actually been film that you had to throw up on a light box. And over time, what's developed is not only the complete digital environment, but the infrastructure and the interconnectivity between sites to be able to move that data around so that now you're able to do what Mark talked about, which is those studies to the best person, best able to read them, and you're no longer limited by the walls of the reading room or the hospital where you physically reside.
And how long do you think it's been that we've had that technology infrastructure that's enabled this to be done?
I think you could do it 5 to 7 years ago with a lot of hoops to jump through and a not very fluid workflow. I think in the last 3 to 5 years, the products have really either been developed or come to market so that it becomes a much easier interconnectivity between locations to be able to do that. You don't have to have an internal IT department. You can go through an MSO or some consultant group to be able to come in and implement that. And I think the hospitals and the different environments have been more acceptable to people coming in and overlaying their own system on top of that.
And the one other thing on that note is we've been doing quite a bit of coverage of the COVID pandemic, and while this webinar isn't really about COVID, it seems like the infrastructure that radiology laid down in these previous years that you referred to really enabled radiology to kind of work from home and make that transition a lot more smoothly than maybe some other disciplines might have been able to do.
I think we were set up for that. I think people kind of look to the model that radiology set to try to follow with the rest of telemedicine as well.
Great. Now, Dr. Krishnasetti, what do you think are some of the big trends that are driving subspecialization? Would you agree with our other guests here today?
Yeah, I definitely agree with Mike and Mark that a lot of the drivers for subspecialization actually come from outside of radiology. As medicine itself gets more subspecialized, we really have to kind of rise to that level of expertise. We really, as a subspecialist, you're able to speak to the referring physicians and know disease processes as well as they do. And that's really necessary to be essential and part of the patient care. If we don't have that level of expertise, then we're really not able to provide the best clinical care for the patient and not really be able to drive better clinical outcomes. And that's what's really driven, radiology to subspecialization. That, along with what Mike was saying, is that there was the forces external that were, driving us towards subspecialization, but also allowing us to do so efficiently. In the past, decade or so, there's been a lot of developments about how we practice radiology. I think even when I came to Columbus Radiology, we were about 20 radiologists, really just covering Columbus, and we invested a lot in IT and that allowed us to spread out across the state because we were able to focus and move studies around to be able to be read by subspecialists and to kind of elevate patient care, even in rural sites across the state, requiring 24/7 neuroradiology coverage or complete musculoskeletal MRI coverage or whatever it may be. But we're able to really be the clinical leaders in those places because of that level of expertise.
Great. Now, Dr. O, do you see changes, or do you see actually variations in the degree to which subspecialization is occurring in radiology based on the size of practices? Are we seeing this trend only happening at larger practices, or are there changes in geography based on where practice is located?
I do think practice size is a big driver of subspecialization in general, just because it's easier to be subspecialized if you have a lot of fellowship-trained radiologists and you have a large volume of studies to allocate to those readers. There'll always be a component of general radiology, even in large groups, as Mike points out. But these large groups do have the luxury of having their key subspecialists interpret enough volume of studies that demand subspecialization. I think historically, geographic location has limited subspecialization in small practices because small towns simply wouldn't have enough volume of high-end imaging to be attractive to subspecialists. And it's also generally more challenging to recruit radiologists to rural locations, as the best trained radiologists tend to have more opportunities to get jobs in areas that may be perceived to be more desirable places to live. But I think as Vikram points out, technology has changed this dynamic. Rad Partners is a great example of how you can aggregate smaller groups through either affiliations or true mergers. In that case, you can distribute study volumes across wide area networks and provide that subspecialized approach no matter how big the town is.
Great. Dr. Brown, what sort of variations do you see?
Well, what we've experienced in Myrtle Beach, which is not metropolitan, the population swells during the summer and during holidays. But what we've seen is that 12, 15 years ago, very specialized care would be delivered at the closest larger city, Charleston to the south, Charlotte to the west. And what's happened over time is that the local places have either developed academic relationships with Medical University of South Carolina. Duke Oncology has done great outreach to different sites in the Southeast that affiliates with some of our community hospitals. We've had local hospitals that have developed residency programs, institute of level 1 trauma centers. We're part of a comprehensive stroke center. Those things have developed over time and necessitate more specialty coverage. So I think everything is done with the eye towards providing better care. But what you see is that as entities grow, the need comes. So larger cities, larger practices, I think by definition are going to need more subspecialized care. And how you grow is varied. You can grow organically and just by volume and hiring more people. You can grow by aligning with groups that are in nearby regions, or you can follow the Rad Partners and model that Columbus has with aligning with groups that are not necessarily geographically close by, but have a similar idea of where they want the practices to grow. And I just don't see how that's going to stop anytime soon as far as the need for continuing to provide new service lines. So one of the things I always say is that you're going to have to hire people, yes, if you add new service lines, but you also need a group of radiologists that are willing to learn new things as you go along. Because not everything ends in fellowship and residency as far as learning. So you do need to continue that process when you join a group and figure out, okay, what are the holes that need to be filled? Am I capable of filling them? And then how we're going to go about accomplishing that.
Perfect. Dr. Krishnasetti, any kind of variations you see in geography or practice size?
Yeah, I mean, I think as Mike and Mark both alluded to, was it's much easier to have subspecialty radiology in larger practices, but that doesn't mean that smaller practices can't or don't, because of the technology that's available. That there's a lot of smaller practices that have partnerships with larger academic institutions in nearby areas. I know that, for a long time, we have Children's National Medical Center in Columbus, and all of the radiology groups in the area partnered with them to provide pediatric subspecialty reads, and that happens in in areas across that, so that you can kind of surmount that practice side limitation of being able to provide subspecialty versus not. And I think that's kind of being blurred because of the technology that's available. So I definitely see different trends, but I don't think that it's only seen in large practice. I think that subspecialty trend is seen everywhere.
Great. So Dr. Krishna Sethi, a follow-up question for you. So what do you see as some of the clinical benefits of having a subspecialist read an exam? What are the patient benefits of that?
So, from this patient perspective, you find that exams that are read by subspecialists are usually read at a higher level of detail, and because of the higher level of training, that's a general rule of thumb. It's not always everybody, but there's a lot of generalists that are still that are good at reading all kinds of imaging, but as a practice and as a specialty in radiology, by subspecialization, we're able to provide that level of clinical care that's kind of equivalent to the level of clinical care that they're getting from their referring physicians. If you have an orthopedist that only focuses on hand imaging or hand surgery, and a specific orthopedic hand surgeon, then it's really difficult for a general radiologist to know that much about the hand, right? Even for a musculoskeletal radiologist, that's another specific, more even super subspecialized area. But we have a better chance of really being able to speak at the same level, and even in our reports or in consulting, be able to really actually add to the clinical care. Because that's really, at the end of the day, is if we're not adding to that clinical care and better patient outcomes, then we're not really performing our duties, right? So as physicians, we really want to elevate that level of clinical care, and subspecialization allows us to do so in certain scenarios.
Great. Dr. O, Radsource has been supplying subspecialty reading services for musculoskeletal exams for a long time. Has demand for an outsourced service increased with the industry shift toward this way of work?
I'd say it definitely has. There's been incremental growth, steady growth ever since we were founded in the early 2000s. And, really the technology, the internet boom made these kind of things possible. I can remember when we, my old traditional radiology group, when we first hooked up to read orthopedic MRI for a local practice, it cost us around $150,000 to buy a point-to-point single connection, and we could hear each individual image come over via a DSL line. So it was kind of early days there. And obviously a lot of things have changed. So now that we can cost effectively and rapidly connect to any appropriate provider throughout the country. One thing about Radsource is that we are pretty unique. This webinar is about subspecialization, but I would argue that Radsource goes a step beyond what you might call super specialization. We hire great musculoskeletal and neuroradiologists and put them in an environment where all they do every day for the remainder of their careers is read MRI in a collaborative, quality-focused environment. So we aren't doing typical subspecialty work such as injections or a lot of CT, but 99% of the time it's MRI. So when I see a difficult or challenging case, I can push a button and get feedback from any of our 25 radiologists in a matter of minutes. So it provides a level of expertise that's really difficult to replicate in a traditional radiology practice. And as a result, we have robust demand, and most of the demand is based on people who are looking for the highest quality they can achieve.
That's amazing. So Dr. Brown, can you talk about how your practice operates with respect to subspecialization? How is work distributed between your practice members, and what proportion of exams are read by subspecialists versus generalists?
So what we've tried to do over the last 3 years really is institute a unified reading platform across the whole enterprise. And the end goal, which is still in progress, is to get to an automated workflow where, based on everybody's identified skill sets and areas of interest, the work will be automatically shuttled to them so that the most appropriate person who's the most available is going to read that study. Right now, we're still reading off of site-specific work lists. So specialists that are at a certain hospital will still see that site's studies pop up, but they're able to go out manually and override that list to provide the specialist coverage that we need throughout the group. So everybody in our group still functions in some general role, no matter what specialized training that you have. So those that are more specialized, the expectation is they're going to read more of the specialized studies. Those like myself that don't have that degree of training are going to read more of the general work off the work list. And as long as everybody does their job, it's fine. In a perfect world, that all works out in the end and the list is always zero and everybody goes home at the end of the day. But as everybody knows, their different sites have different requirements, administrative tasks, phone calls, procedures, those things get mixed in. And so sometimes it does get a little bit jumbled on how you're going to get that accomplished. So what we're trying to do is leverage the IT to help us solve that problem. I would say right now, neuro is, if you call high-end neuro, and I'm not saying, the routine stroke workup, brain MRI, but ordered by neurologists, ordered by neurosurgeons, it's read by neuroradiologists. We try to sort of follow what Vikram talked about, which is we want to have people speak the same language to the ordering physician. So if it's a specialized physician that's ordering the study, then it's deserving of a specialized radiologist giving that read back. And so I think what changes as either your roster of subspecialists grows or the group size grows, is that you're able to expand what you consider to be a subspecialty exam. And define those different, and that can be fluid as you go along. And so that's the way we accomplish it now. I mean, it's like I said, it's on the spectrum toward the IT solving some of those issues, but right now it's still kind of a manual distribution.
Great. Now, Dr. Krishnasedi, do you see a need to take proactive steps to make sure that radiologists who are specialized in a particular area, that they don't fall out of practice reading outside of their specialty or their subspecialty?
Yeah, I mean, a lot of that's taken care of by the IT system we have. We have smart work lists that basically kind of morph into what needs to be done for every single shift that we have, and kind of move subspecialty care and subspecialty exams to the subspecialist that's able to read it the most effectively and the most timely manner too. And so part of that as well is that no matter how much subspecialty work there is, and for us, subspecialty is not just MR, it's also subspecialty CT and sometimes even subspecialty ultrasound and plain films too. We divert some of that work towards a subspecialist, but no matter how much subspecialty work there is, even if you do all of that, there's still a large pool of general cases. And it's still actually the larger part of the volume. It's the majority of the volume, no matter how you cut it. Subspecialty exams, get a lot of the press, but there's a lot of general work to be done. There's, X-ray volume is still the largest volume that each radiology practice has that's, practicing in hospital sites. So what we do is we allow, our radiologists to read subspecialty exams, but also they help out with all the general work, and it's shifted to them so that they're still reading subspecialty exams most of the time, but in any given day, they're also reading a small portion of general work as well. So that way, proactively, that nobody's ever got really fallen out of touch. We don't have a neuroradiologist that's never read a CT abdomen, pelvis in like 2 months. We don't have that because we move things around so that they're able to cover the emergency rooms. They're able to take call. And the reality is in any practice, you don't want to have 15 radiologists of different specialties taking call for exams, that may only need 3, right? So, and so we want to make sure that everybody is still proficient, because at the end of the day, we're still, we having that understanding of all the different disease processes it's helpful when you're, even if you're reading a head CT, because a lot of these things aren't confined to one, organ system. So having that background is still helpful, and so being proactive about allowing our subspecialists to still read general work is important. And actually, I think we had it was kind of a dividing point a few years ago of do we we had enough subspecialty work to just have subspecialists read only their subspecialty 24/7, every single day, every single shift. But we made a conscious decision, and everybody kind of didn't want to go that route. We said that, you know, having that that knowledge base in general radiology is, you know, is still a really effective tool, and you know, and it helps with the patient's overall clinical care, and also it doesn't pigeonhole us. We're able to be subspecialists and in a certain field, but also understand, you know, the general field in itself too. So.
Right. So, Dr. O, do you think there's a need in the industry for different subspecialty groups in different disciplines, which would allow facilities to offload all their subspecialty work to subspecialists?
I think, you know, the trends economically and industry-wide are going to drive towards more and more subspecialization. But I think Vikram's point is great in that you can go too far, and if you get to where you're just having everything be subspecialized and into these isolated silos, you lose some important things. I mean, prior to Radsource, I was president of a 60-man radiology practice, so I kind of understand the other side too. And you know, it got really, as we went too far down subspecialization, it got to be where, you know, people on call could only do a very limited skill set, and we had all these backup call situations going on, and that became problematic, and we actually pivoted back more towards people being able to do a little bit more of everything. But there's no doubt we can't stop subspecialization. I think one thing people need to recognize is that often people think he's fellowship trained, that makes him a subspecialist, and that means he's good. But Vikram can probably tell you we're both MSK, and if I think back to what I knew or didn't know when I got out of my fellowship, it's horrifying to think, you know, how I would read today compared to how I would read when I first got out. So we only hire people that are experienced, typically about 10 years before we hire them, and we actually have a unique step in our process where we'll throw them in a dark room and make them read 8 or 9 MRIs as a test prior to offering the job, and it's shocking really that about half of the people fail that exam, and you know, some of these are like attendings or teaching fellows on a daily basis, and we don't feel they can adequately read the studies. So I think subspecialization is important, but measuring quality is going to be increasingly important, and I really hope we find a way that we can do that effectively in the future.
So are you using any tools to do that right now, or is it more sort of an ad hoc thing?
Yeah, I mean, obviously we do things like ACR RadPeer, but I think the most valuable feedback we get is the fact that we communicate very often and regularly with our referring orthopedic surgeons and spine surgeons. And so we see feedback. We'll keep a list of interesting cases that will be a number in the 100 throughout the year. Then we'll go back and ask for operative reports on all those patients to get pathologic correlation. But we developed relationships where the surgeons know that if they find something that they didn't expect, they'll just pick up the phone and let us know, and we'll review the images. We're not defensive. We just see that as an opportunity to learn and get better.
Great. Dr. Brown, you mentioned information technology a little bit earlier. Can you dive a little bit more in detail on that, and what sort of changes has your practice made in the last few years to let you operate the way you do? What changes have you made in terms of information technology?
Well, the biggest thing we did was institute a unified reading platform, and that came about because in our region we had 7 different hospital systems. As we covered different places, we had 7 different PACS systems, and so call became kind of a nightmare. And what happened is, you know, after a recruiting cycle of realizing that we're probably putting people in an environment where it's going to be really hard for them to succeed in a timely manner, we looked at it and said, we need to start working smarter, not harder. And so I kind of championed these efforts starting about 5 years ago. It took a lot of time to get buy-in. You know, as Vikram said before, it's not an inexpensive proposition to do this. As Mark knows, for offering these services, it's not an inexpensive a product to provide. But I think what you have to do is sometimes, if you're not fortunate enough to be able to learn from other people's mistakes, then you have to sort of go down that pathway on your own. And unfortunately, we didn't get very far down the pathway before we backed up and said, okay, let's reset a little bit. Putting that platform in place has allowed us to recruit easier. It's allowed us to get studies moved around, not only just specialized work, but just work balancing in general throughout the day. And then you brought up COVID before. It's made a seamless transition. We've unfortunately had, in a 44-person group, we've had, about 10% of our workforce at one point or another go down with COVID or be exposed. And so we've been able to transition to remote stations from home, keeping everybody else isolated, but still allowing those physicians who are minimally symptomatic or asymptomatic to continue to work. And without that, I think we would have been in kind of a bad way early on. And so having that in place, we didn't really need to do a whole lot to adapt. And so that IT side is the software side of things. We had to hire, IT support staff. We had to really contract with people that could support them if the problems got to a level that they couldn't take care of that. And backbone-wise, it comes down to, as we experienced a little bit earlier today, your connectivity and your bandwidth. We've been fortunate to have a pretty good fiber backbone for a metropolitan area. And so that's really been the crux of what we've been able to build off of. And so we don't see a drop-off in productivity, regardless of where we're reading from.
Great. Dr. Krishna Sethi, can you talk a little bit about the platform and you maybe also some of your experiences with COVID and kind of how the technology enabled you guys to get through that?
Yeah, absolutely. Many years ago, we kind of invested in a lot of infrastructure, and we've grown it since. Even with Columbus Radiology, which is named Columbus Radiology, but it serves Ohio, and we have radiologists in California and Hawaii. We have an office in Hawaii, and so we're really able to provide 24/7 subspecialty coverage. And when COVID hit, it really was, we didn't even skip a beat. We just basically shifted some responsibilities that were no longer in the hospital to other places, but every single one of our radiologists has a home workstation. We have multiple remote sites that we could read from, and so there was no difference. So having that IT platform and IT backbone and investing in it was important for us to kind of continue our business without having any issues. Actually, even during the whole COVID shutdown and everything, we actually brought up like 4 different new sites, which in about 5 years ago, that would have been impossible if we weren't able to actually be there. But we actually were able to support everything, bringing up brand new hospital systems that we had never actually set foot in, but able to bring them up. And then as things got a little bit more lax as far as quarantining and stay-at-home orders, we're able to come into those hospitals and transition back to these hospitals also seamlessly, because it's the same technology everywhere that we read. And so we're able to provide all the same level of subspecialization that we did, even with either decreased staffing or decreased volume, more like during COVID, and really didn't change our level of service at all. So that was
good. So Dr. O, so Radsource, on the technology side, Radsource is also a PACS hosting platform. And on that front, has demand increased with regard to clients desiring a platform that lets them divide their work by subspecialty?
Yeah, I think no doubt. I think obviously Mike and Vikram have practices where they've got mature, very robust solutions to dedicate their work, but there's still a large number of radiology groups out there that have what kind of Mike described as the kind of rotating chair PACS war room, where you have 6 different systems. You're going back and forth to read your volume. So we've had numerous radiology practices reach out to us to kind of improve their systems, allow them to obviously read any case from any client from anywhere. And doing this at home is what we're doing at Radsource. And of course, Radsource is kind of built for the pandemic, because the radiologists I hire live anywhere they want and read MRI. So they actually probably saw the least impact of the pandemic on their jobs as probably almost anyone in the country. But for a lot of other radiology groups, that's not the case. And Vikram and Mike have great systems, but for the groups who don't, they're now realizing even more acutely because of the pandemic, how they need to get on board and have that kind of efficiency for their work and for their lifestyle as well.
Yeah. Now, Dr. Brown, another sort of COVID-related question. So one of the greatest challenges in the face of the pandemic is the need to keep both patients and your staff safe. What steps have you taken to accomplish this?
Well, as far as the patients go, I mean, following just general government and health facility guidelines, universal masking at our facilities early on, I think was kind of nice to have them buy in and start. We did try to get pre-procedure testing done for some outpatient things that were being done in the interventional suites or that would potentially be aerosol generating, like lung biopsies. And just with the lack of testing availability, we couldn't go down that way. So we had to rely on, questionnaires and making sure they weren't febrile and no exposures. All we tried to do with our staff and with the radiologists was keep ourselves as safe as we could and figure that we were going to do the best for our patients that way. As far as the staff goes, we just encouraged them to follow guidelines that the hospital set forth. We did try to minimize all the interactions that we didn't feel were really necessary. The trips from a tech back to a reading room to ask a question when it could have been done over the phone. We did try to close off reading rooms to non-clinical interaction. So clinician needs a question answered, they have to come down and we should be reviewing things with them. But the ancillary staff that may need to come through the reading room to do something, we tried to keep that to a minimum if possible. And then as far as the radiologists go, like I said, we just tried to make everybody understand that, if you're not feeling well, you may have been exposed, stay home. We can adapt. We can put you on a shift where you can work from home. We can figure out a way to put you in our centralized office where it's partitioned off and there's not a lot of people there. I think in general, we just did the best that everybody probably tried to do in this environment, with PPE sometimes being not scarce, but not as easily accessible. Getting an N95 under lock and key from a centralized cupboard sometimes was tough to do. But what we tried to do was just try to keep everybody in mind and try to look out for everybody equally and not ask anybody to do anything and take any risks that we ourselves wouldn't take. Yeah. And I think for the most part, people were pretty responsive to that.
Yeah. Dr. Christian, any special steps you guys took during the pandemic?
As Mike was saying, we took those universal masking, and when we opened back up the outpatient centers, we followed all the guidelines of social distancing, et cetera. But one of the big things that did change during the pandemic is we worked with our hospital systems to really protect our technologists, because there was a lot of exams that were being performed on persons of interest, so basically rule out COVIDs or positive COVID tests, and how we handled those. And before this, it was if a physician ordered an exam, it got done, right? And now we had to really protect our technologists, protect the other patients, because if there's an exam that's done on a COVID positive patient, there has to be significant sanitizing of that CT scanner or MR scanner, and it takes time, and it could delay imaging for other patients. So we actually had any exam that was being performed on a rule out COVID or COVID patient that actually had to go through radiologist approval, and that was at request of our hospital system. So across the state, we had we had conversations with a lot of emergency room doctors about doing that, and it actually was taken very well by the ER docs, because they also saw that as an opportunity to say, is this really the best test? Because even if we are going to perform a test, this might be the only one that we do. So let's make sure that we get the right one to answer as many questions as we can. So it gave us a lot of opportunities to really be consultants in that clinical care. And it was really necessary, because that was how the hospitals could stay open, by keeping their staff healthy and avoiding the spread from patient to patient as well. And so by doing things like that, we decreased, or really minimized that risk in the radiology departments at least. So that was one of the big changes we made. And then, as Mike was saying too, most of us worked from home during that, and we really limited hospital in-person time to what was really needed, or which we didn't cancel procedures, we didn't do anything like that. So we still did all the in-hospital stuff, but provided things that could be provided remotely, we did. So
Good, very good. Well, I think this could be a good time to take some live questions. If you would like to ask a question of our panel, please use the Q&A button at the bottom of your screen there, and we will proceed to querying our panel, anything that you want to know about subspecialization in radiology. So we will take us just a few moments to connect, and we will be right back.
And we are back. So we will be taking questions for, we got up until the top of the hour, so we got about 20 minutes. We do have Dr. Brown and Dr. Krishna Sethi with us, and hopefully Dr. O will also be able to join us. So if you'd like to ask a question, please use the Q&A button at the bottom of your screen there. And let's, I guess if we can get started, what kind of advice do you have for residents who are thinking about getting into, who are about to finish their residency program? They're about to become full-blown radiologists. What advice would you have for them in terms of whether they should pursue a subspecialty or whether they should try to be a generalist? Dr. Krishna Sethi, could you tackle that one?
Yeah, I mean, I think that it's going to be a personal decision of what interests them, but choosing a subspecialty and getting more training on a specific subject is always a good thing to try to increase your knowledge base, and having those skill sets is going to be valuable to any future practice or job or any place that you go. And that goes with anything, is having extra skill sets in any specific part of radiology, be it a subspecialty fellowship or just in general. When you join the practice and learn new things, it's always going to be more valuable to increase that education. So
great. Dr. Brown, a question here from the audience from Nora. Since we clearly cannot escape general work, is it then okay to choose 2 subspecialties early on in residency?
I presume the question is more about if you increase your subspecialization, what are the job prospects going to be? And I think there's always going to be some general aspects to most jobs. I think Mark's group is unique, and I don't know of too many others out there, where it is a very niche subspecialty practice where you choose to super subspecialize and read those studies. And you probably can't avoid a lot of the other aspects of radiology that you go through with residency training. I think what's going to happen is, as you start to think about jobs, there's going to be a certain degree of subspecialization that may be expected when you come out of fellowship. And I think what's going to happen is there are going to be jobs that either skew more towards the side of needing more subspecialization, or jobs that skew more towards the side of needing more general skills. So I think all you're doing by choosing multiple subspecialties, if you do 2 fellowships, for instance, you may just be partitioning off a set of jobs that you're just not going to consider at that point, because they won't be able to take full advantage of your subspecialization. They might require more general skills that you may not want to pursue. So I think when you make those decisions, like Vikram said, I think you should choose things that you're interested in. I don't think you should try to game the system for the job market and figure out what's in need now. If you don't like women's imaging fellowship, if you don't like IR, don't do an IR fellowship. But if you love those things and you are passionate about them, you're going to find a job doing those things. There are going to be jobs available to you. I just did a residency lecture yesterday, and one of the things I always tell them is, identify early on where you want to start to interact with the groups. First, second year, just send out a notice of, hey, I want to work in this area. And you can start to get a feel for what's needed out there, but that should be what you're interested in.
Okay, Dr. O, you mentioned during the earlier discussion, and then also Dr. Brown mentioned this idea of super specialty. Do you think that that's going to be like the next step? We've gone from a specialty to subspecialty to super specialty, or is that something that's really going to be more of a niche, something that just a few practices do on a niche basis?
I think, both Mike and Vikram made the point that in a typical practice, you need to have a certain broad skill set in order to work efficiently, particularly in things such as call. Our situation at Radsource is unique, as Mike pointed out, in that we are able to aggregate a large volume of musculoskeletal and neuro MRI and dedicate our practices to that. And I certainly love the work, and I think all our radiologists enjoy that job. But as far as to what extent that will occur nationwide, I think it's, current specialties, whether you're a neuroradiologist or a breast imager or a musculoskeletal radiologist, those are pretty well defined and useful designations. I don't think you're going to see a lot of, musculoskeletal ultrasound being all you do, or, further division. Certainly within any subspecialty, there'll be experts that do their research and dedicate a lot of what they do on a daily basis to certain facets of that subspecialty, and that's important. That's how the field tends to advance. But from a day-to-day, broad national perspective, I think the super specialization approach is not easy to pull off logistically or economically, and so I think it's going to remain kind of a niche environment.
Okay, so this is a question that I'd like to kind of throw out to the group, and anybody can grab this one. This is from an attendee. It was mentioned that insurance requirements are encouraging subspecialty reads. What criteria are being used or proposed to determine the subspecialist credentials, i.e. CAQ, fellowship training alone, without additional certification or case numbers? So anybody want to dive in and grab that one?
And I guess I could take a shot.
Good luck.
I can Mark jump in. So part of this is the difficulty of answering this is it's evolving, right? There's not a lot of insurance providers that are mandating this quite yet, but it is evolving. And there currently in radiology, there's only a few specialties that truly have a CAQ, which is neuro and interventional. Body imaging, musculoskeletal imaging don't have a CAQ. They just have fellowship trained. So there, we've seen both. We've seen places where, places where you can get a CAQ, they require a CAQ. Many places when we have neuroradiologists read, they require a CAQ neuroradiologist to read them. Other subspecialties such as musculoskeletal, where a CAQ isn't available or isn't required, it's usually a fellowship training or showing some proficiency in that. And that's where it gets a little bit hazy about what proficiency is and how many cases is necessary. And that really hasn't been defined yet. So it's, that's about all I have.
Okay. Anybody else want to add anything to that?
I mean, I would add that, we are seeing some situations where a payer may say, for example, for MRI, that it has to be an accredited facility, and maybe it has to be a certain field strength and above, and it should be read by someone who's fellowship trained, and that facility may get preference over another facility. But I think the biggest challenge in radiology and medicine in general is, is that enough to say, if you have meet those criteria, check those boxes, does that mean you're getting quality? And I think the answer is that's not true. We see lots of people that are fellowship trained that aren't the best, and and facilities, you can have a good piece of equipment, but if you don't know how to run those protocols, design those pulse sequences, and you're not going to get an effectively diagnostic study. So it's a challenge, and in some ways medicine, there is some fear of measuring quality, because what do you do if we may put strict guidelines on radiologists and we find that 20% of them shouldn't be practicing? Would be a devastating thing for the American College of Radiology to deal with. So I think it's a challenge that needs to be addressed, but it's going to have to be, obviously there's a lot of trepidation and things to step carefully around as you measure that quality. But the bottom line is the patients are going to be better served if we can figure out a way to effectively do that going forward.
Great. Dr. Brown, anything you'd like to add on that front?
I don't have a whole lot of experience with private payers, but I do know that, Mark probably has some contracts with some subspecialist offices. And one of the ways that groups do get business from orthopedist offices that own in-office imaging is by having a staff of people that have some quality metric, whether it's fellowship training, whether it's CAQ, to be able to compete for those contracts and get the reading contracts. You might need that. So while that's not exactly the payer question I think that was asked, some of those services are list billed to those offices, and you will need that type of credentialing to provide those services.
Okay, so we've actually got several questions here on artificial intelligence, and I know that AI has been really the hot topic in radiology over the last 3-4 years, and so let's take the last few minutes we have to kind of dive into that. Are there any particular areas of subspecialty practice that you see are particularly well suited to AI analysis? And if that's the case, should radiologists be worried about that? Dr. O, do you want to tackle that first?
Yeah, I mean, I find AI very interesting. I think there's a lot of buzz about it now, but what a lot of people don't realize is that it's been around for quite a while. When I was doing my residency at University of Chicago in the 90s, we were using machine learning to evaluate pulmonary nodules and breast disease. So it's been out there. Of course, CAD has been around in mammography for decades now. I think it's, at RSNA, the AI showcase, you look at things like interstitial lung disease, which is super hard to interpret, certainly for me, just looking at the CTs and trying to determine what that pattern means. AI's looks like it's pretty promising there to look at things in a whole different way than a radiologist does. I think the promise of AI is that, the way we perceive pathology is based on certain pattern recognition, things that we've learned, but the computer who has no bias may find entirely different ways to arrive at the correct diagnosis. And I think that's exciting. I see AI not so much a threat to the specialty as something that's going to help us be more efficient and faster and better going forward. So I don't fear it. From a medico-legal perspective, I think there's always going to need to be a radiologist to do the final sign-off on a study. The simple fact that you can't sue the algorithm is a part of that. That's going to mean that radiologists need to stay involved. So there's fear of technological advancements in AI, and I think we need to be judicious about how we use it, but I actually think it's an attractive thing. It's going to help us going forward.
Great. Dr. Krishnasetti, what are some of your thoughts on AI and subspecialty practice?
Yeah, I agree with Mark. AI has been around for a long time, and people have been using it. And recently, the advancements and what all the buzz is because of the computing hardware has gotten to a point where making an AI algorithm is easier. But that all being said is, I think that, AI is a disruptive force in radiology, and that's not a negative thing. MRI was a disruptive force in radiology, years ago. And when MRI came out, there was articles saying that radiologists would no longer be needed. And then the title said, images are so clear that anybody can read them. And we obviously did not go down that path. And AI is going to be the same thing. The radiologists that learn to use AI and incorporate AI in their practices are just going to be able to do their jobs better and more efficiently with better clinical care. It doesn't mean that they're not going to be needed. It just can be another tool in the tool belt that radiologists have to impact patient care, and it's going to advance the field and really maybe even make us more necessary because of how much more we can add to patient care. So I don't think it really has any threat of replacing any subspecialty, and I don't see any specific subspecialty that AI is targeting. It's kind of everywhere, and it's still, even though it's been around for a while, it's still in its infancy, and it's still jury's out on exactly what it's going to be able to help us do. But I think everybody's in agreement that it will help us be better, more efficient, and better clinical quality, and that's a good thing. So
great. Dr. Brown, some thoughts from you on AI and subspecialty practice?
Yeah, I think what's going to happen first with AI is simply basically functioning as a pre-reader. I think AI is set up very well for trying to route studies that it thinks are pathologic, abnormalities that need to be addressed, to route them to somebody who is most capable to read the study fastest. So, there are algorithms out there, FDA approved, to identify subarachnoid hemorrhage, for instance. that it's great to be able to get that to a neuroradiologist quickly, knowing that there's pathology. Doesn't mean that there always is, but it tries to flag studies that it thinks potentially might be abnormal. I think that's one way that AI can help a radiologist. The other is in things like mammography. There are products out there that are, sort of super CAD. CAD, I think everybody who reads mammograms has come to learn, it is basically useless. I can't imagine, I can't think of the last time that on a regular 2D CAD that it really truly helped me. I spend more time dismissing the CAD marks that are completely ridiculous than it does help. But things like Tomo with better algorithms, I think what happens is you can get confidence out of it. There are products out there that will flag it as red, yellow, green as far as abnormal, sort of abnormal, and normal. And what that does is help you as a radiologist reading a screening exam to say, I'm confident that this is low risk, that it's as close to normal as can be, and pass that along to the next. And conversely, when there's something abnormal that it flags, have confidence in it that it truly is finding the abnormal exam. I don't think AI is ever going to replace the radiologist. I think if I were in training now, I would start to figure out how I'm going to coexist with AI. I would figure out how I'm going to incorporate it in my practice, how I'm going to utilize it going forward. If you're at a program that has exposure to it, I think that's great. And I think the other thing that pushes AI being a force down the road is as practices get larger and as we can leverage more IT solutions, I think AI is going to be easier to implement in the larger practices. And if it does pan out to be worthwhile, I think you're going to put pressure on the medium and the smaller groups to be forced to implement it to stay competitive.
Great, good. All right, so well, some great thoughts to conclude the talk today. I'd like to thank Dr. Vikram Krishnasetti, Dr. Michael Brown, and Dr. Mark O for being with us today. I think it's been a great discussion. And I'd also like to thank our sponsor today, IntelliRad. Thank you for your sponsorship. You made this possible. And finally, we'd like to thank all the attendees who showed up today. Thank you for taking time out of your busy day. And we hope you found this webinar useful. Signing off for AuntMinnie.com, my name is Brian Casey.
Thanks.